Right, so welcome back. So this is part 8, and this is likely going to be our final part of our articulations lecture. And so in this part, we're going to finish up by talking about the hip joint. We'll then move distally, and we'll talk about the knee joint as well. So in talking about the hip joint is sometimes referred to as the coxal joint. It is very similar to the elbow joint. All right, I'm sorry, it's very similar to the shoulder joint. Excuse me. So the shoulder joint, it was a synovial joint. It was multi-axial, it is diarthrotic. We're gonna see this, it's ball and socket. We're gonna see the same thing with the hip joint. So the hip joint is synovial, it is multi-axial, it is ball and socket, and it is diarthrotic as well. So it's similar to the hip joint in that respect, but it's also slightly different in the sense of its stability as well as its mobility, right? So if you think of your shoulder joint, assuming you're healthy and you have no illnesses or anything going on with your shoulder, you haven't injured it in any way, you have a fairly good range of motion in your shoulder, right? You can move it anterior and posterior, so you can flex it and extend it, you can abduct it and adduct it, you can circumduct it, you can rotate it, you can perform a lot of different movements with the shoulder, right? Well, if you think about the hip, you can do the exact same thing, just not to the extent that you can with your shoulder, right? So with your hip, you can flex it and extend it, you can abduct it and adduct it, you can circumduct it, and you can also rotate it as well, okay? So these are similarities between the two, but they're also different. So we said one, you can't move it quite as much, and what that then implies about the stability of the joint is that the hip joint is more stable than the shoulder joint, right? So because it's more stable, it's then going to be less mobile, and that's what we've just seen, all right? So if we look at the hip joint itself, we can see a number of similarities between that and the shoulder joint. So one, it's a ball and socket joint. So just like the shoulder joint is ball and socket, so is the hip. The ball in this case is going to be the head of the femur, where it was the head of the humerus in the shoulder joint. And then the socket is going to be the acetabulum for the hip joint, whereas it was the glenoid cavity or the glenoid fossa with the shoulder joint, right? Also, a similarity between hip and shoulder is the labrum, right? So if you recall, the labrum in the shoulder was known as the glenoid labrum, and it served to deepen the concavity, deepen the socket that the head of the humerus would fit with, right? What it would articulate with. And so you see the same thing in the hip joint, except now you call it the acetabular labrum because it's associated with the acetabulum and not the glenoid cavity, all right? But the function of the labrum is doing the same thing, right? You can also see, if you look at a model of a hip or something compared to a model of the shoulder, there is far more contact with the femoral head by the acetabulum than there is contact with the humeral head with the glenoid cavity, right? And so this is one of the reasons why you have a far greater range of motion with the shoulder than you do with the hip, is because there's less bone on bone, or less articulating surfaces in contact with each other in the shoulder, so you can have more movement. But then again, as we've said several times, that then lends it to being slightly less stable, right? So one of the stabilizers of the hip is you have some muscles, so you have some internal and external hip rotators. You also have various ligaments as well, all right? So if we look at some of these ligaments, they are named according to the bones that they attach to, and they're very descriptively named, right? So there's one called the iliofemoral, one called the ischiofemoral, and one called the pubofemoral. If you look at the first half of each of these names, so ilio, ischio, and pubo, these are referring to the names of the bones of the hip, right? So we have the ilium with the iliofemoral, we have the ischium with the ischiofemoral, and we have the pubo with the pubofemoral, all right? So they are going to attach from the ilium to the femur, or iliofemoral. So that is this one that you see right here. Ilium up here, femur down here. This is the iliofemoral. You look at the ischiofemoral. We're running from the ischium, which is this bone down here, over to the femur. So that's ischiofemoral. And then you have pubofemoral running from the pubis over to the femur, right? You can sometimes see it in an anterior view. You can also see it slightly maybe from a posterior view as well, right? So these are going to help stabilize the hip, and they are tight, or they become taut when the hip is in extension, all right? So whenever you move your hip backwards, so you say you're standing and you move your whole leg backwards, that hip becomes tight, right? It becomes taut. The ligaments become taut. So you can move your hip more coming forward, coming anteriorly. So when you flex it, then you can when you move it posteriorly when you're extending it, right? So if you think about this, if these ligaments, the ilio, ischio, and tibiofemoral ligaments are becoming more taut, they're becoming more tight in extension, what does that mean about the likelihood of dislocating your hip while in extension versus flexion, right? So think about it for a second. If they're becoming more tight, more taut while in extension, that's going to make you less likely to dislocate the hip while in extension, but you're more likely to dislocate it while you're in flexion, right? And you can test this very easily yourself. If you're standing up, or if you're not standing up, you can stand up now. If you extend your hip posterior, and so you bring your leg backwards, try to then move it side to side a whole lot. It's kind of hard to. You can move your lower leg, but to move the actual hip, it's kind of hard. Then if you bring it anterior and you flex the hip, you can then move your hip a great deal, right? It's because of the tightness of these ligaments. They are much more taut, much more tight while you're in extension than they are while in flexion, okay? Now, another big thing about the hip is we know that oftentimes the hip can become damaged in terms of the bony articulating surfaces, so the head of the femur or the acetabulum, and then a hip replacement is warranted, right? So a total hip replacement is a surgery, a procedure in which the kind of neck region of the femur as well as the head of the femur are removed, as well as part of the acetabulum is modified, and it is replaced with a metal and a synthetic femoral neck and head, as well as a metal acetabulum, right? So what you see here is we're going into the right side of the right hip. They then take a saw and they remove the neck of the femur as well as the head. They then remount the acetabulum. So what this is doing is this is taking the maybe somewhat irregular or kind of narrow shape of the acetabulum, and it's reaming it out, and so it's making it much larger and it's making it a bit smoother as well. They then can insert a new acetabular cup that sits in this new reamed out acetabulum, and so this metal cup goes in there. They can then insert a large metal rod into the medullary cavity of the femur, so they have to ream out the medullary cavity, and you can see this on this x-ray to the right, just how deep this medullary rod goes into the medullary cavity of the femur. And then you have this new rod that is kind of cemented in place in the femur. You then have an artificial neck coming up. You then have an artificial head of the femur that then articulates with an artificial acetabulum. Okay, so this now smooth new femoral head is able to articulate nicely with the smooth new acetabular cup that was inserted after the acetabulum was reamed out. Okay, so this is a relatively common thing that has to happen as we age as a result of being, we're bipedal and we put more weight and stress on our hip joint. All the weight from our upper limb is distributed down onto the femurs first, and specifically onto the femoral head. And so it makes sense that over time you're going to have some breakdown and some degradation of this structure. You could have osteoporosis, arthritis. These different things could warrant a total hip replacement. All right. So if we move down past the hip, we then get to the knee. All right. So the knee joint is also referred to as the tibiofemoral joint because it involves the tibia as well as the femur. Right. So here's our tibia distally, this large bone here, and then we have the femur more proximally. So we have the tibiofemoral joint. This is a synovial joint. So you have a synovial membrane, synovial fluid, joint cavity, capsule, all those good things. The knee joint, as we'll see in a second, also has several accessory structures that other joints don't necessarily have. So it's synovial. It's going to be considered a hinge, but a modified hinge. So what this means is that it doesn't just move in a hinge-like pattern, a hinge-like motion, but it also has other slight movement, and this is a slight rotating movement, right? So the knee, whenever we stand straight up and we lock our legs, right, the knee slightly laterally rotates, right? Whenever we unlock the knee, we have a slight rotation of the knee that causes the knee to become what we just referred to as unlocked. All right, there's a muscle in the posterior aspect of the knee called the popliteus, and this popliteus muscle will slightly rotate the will slightly rotate the rotate the knee laterally, and this will unlock the knee somewhat. All right, so you can tell when you're locked, you have to kind of unlock your knee, and it slides and it glides a little bit. That unlocks your knee, it causes it to slightly flex, and then you can go about moving and do whatever you need to do. All right, now associated with the knee, you also have several other connective tissue structures, right? So you have a capsule that surrounds the knee, but you also have things called menisci, and you also have ligaments, all right? So menisci that we'll look at first, menisci are these C-shaped pads of fibrocartilage that cushion the space between where the femur and the tibia meet. So where the condyles of the femur, so the femoral condyles, and the condyles of the tibia, where these two come together, in between you have both articular cartilage and you also have these menisci, right? So you may have heard of menisci, you may have torn a meniscus if you play some type of sport or exercise or run or something like that. But it's these C-shaped pads of cartilage that you see here, all right? So the femoral condyles will come down. Instead of resting directly on the bone, they then kind of rest on these menisci. And of course, like similar to the hip, over time these can break down and wear down, and you may have to have a knee replacement instead of a hip replacement, right? But this is fibrocartilage, so it's shock absorbing, it is compression absorbing, and it's going to be able to withstand some of the pressure and forces that are applied on it over a lifetime, right? So you have a medial one on the medial side, you have a lateral one on the lateral side. When you look at this view here, the way you can tell which one is medial and which one is lateral is by the location of the fibula, right? So we know that the fibula is a laterally located bone, and so because it's laterally located, the meniscus closest to the fibula is going to be the lateral meniscus, and the one on the opposite side is going to be the medial meniscus, okay? All right, so you have these menisci. You also have cruciate ligaments, right? So cruciate ligaments, the term cruciate kind of refers to the term crucifix, which means a cross, all right? So these cruciate ligaments, there's an anterior and there's a posterior, form a cross. They form an X and they move past each other, all right? The ACL is on the anterior aspect. So here's the same view again. Here's posterior back here, here's anterior down here. So here's anterior, here's the anterior cruciate ligament, here's posterior, here's the posterior cruciate ligament. The anterior cruciate ligament you can see from an anterior view, and it prevents the anterior displacement of the tibia relative to the femur, all right? So in other words, it prevents the tibia from moving too far anteriorly, too far forward, right? So in instances of hyperextension, this ligament may tear. So preventing preventing hyperextension is one of the roles of this ACL, of this anterior cruciate ligament, right? The PCL is preventing posterior displacement of the tibia relative to the femur. So it's preventing hyperflexion. So it's preventing the tibia from moving too far posteriorly relative to the femur. So some type of trauma when the leg is flexed may cause the PCL to become damaged, right? So if we look here, you can see that an ACL tear involves the tearing of the anterior cruciate ligament. So here's our knee, here's our patella, and here's the anterior cruciate ligament. This can be caused by some type of blow to the knee. So if you're running and somebody hits you or falls on you from a lateral aspect, it could cause the ACL to tear. Some type of strong contraction that pulls on the knee and causes this ligament to rupture. Sudden changes in direction. So if you're jumping, you're running, you're turning, this can all cause it. And then it's common in extension as well. And as we said, the ACL prevents hyperextension. And so if you're in an extended position, you're more likely to tear than you are if you're in a flexed position, all right? Now, because these are ligaments and tendons, or these are specifically ligaments, but they're similar to tendons in the sense that they don't have a blood supply, right? So because they are avascular, this is going to significantly hinder their ability to heal on their own. And so some type of surgical procedure, surgical repair, or reconstruction will be necessary for an ACL tear, right? Now, you can have another condition that we'll look at in which you take this a little bit further, and this is called the unhappy triad, right? And the unhappy triad, the term triad refers to three, and you tear three things at once, right? So you tear the anterior cruciate ligament, you tear the medial collateral ligament, and you tear the medial meniscus, right? So here's your ACL, right? So here's the knee, here's the fibula, here's the tibia, this is anterior, this is posterior back here. Here's the anterior cruciate ligament. Here's the medial collateral. Collateral means on either side. So the medial collateral is on the medial side and the lateral collateral is on the lateral side. And then here is the medial meniscus, right? So in the unhappy triad, you have some type of blow, some type of trauma to the knee in which you tear all three of these at once. So you tear the ACL, MCL, and medial meniscus. The reason you tear the medial meniscus and the medial collateral ligament, the MCL, is because they're actually attached, all right? And they are attached unlike the lateral collateral ligament and the LCL, or the lateral meniscus. These are not attached, but the medial collateral ligament and medial meniscus are. So when one tears and pulls, it's likely to pull and tear the other one as well, right? So this is another thing that can happen if you play sports or exercise or run or experience some type of trauma to the knee, blow to the knee, sudden sharp turning and twisting. All these different things can result in a tear of all three of these at one time, right? So very unhappy for you. Okay, so we are finished with our articulations lecture. So there were 8 parts total, I believe, so make sure you view them all in order. And as always, if you have any questions, if you have any concerns about any of the material, feel free to reach out, and I will see you in the next video.